I spoke, I think, for about an hour yesterday, so today I'm going to keep my comments much, much shorter. I'd written a paper, 10 Reasons Why States Shouldn't Expand Medicaid. It makes a lot of the same points we just heard. So instead of going through sort of a litany of the technical reasons, I want to back up and focus a little more on some of the discussion we had yesterday before I spoke, the whole concept of federalism, this relationship between states and the federal government, which is really about the relationship between we, the people, and the federal government. And I was also asked to talk about this from a physician's perspective, so I was thinking this morning, well, how are we going to cover all that? So here we go. It's going to seem a little bit disjointed to begin with, but I'm going to tie it all back together with the concept of federalism. So just talking about the patient-physician relationship, I talked about that quite a bit yesterday, and just sort of three other small examples today about what's happening, because I still am a practicing physician, practice internal medicine, hospital medicine, critical care. And what do I see on the inside as a physician? And there's an interesting survey that came out, I think it was about a year ago, by the Doctors Company. It's a survey of just over 5,000 physicians, and they sold insurance. So this isn't a left-leaning group or a right-leaning group. So it's a pretty good survey with a fairly good power with 5,000 people. And one of the questions they asked is, given what you know about the Affordable Care Act, how likely are you going to retire in the next 5 years? And it's sort of a Rasmussen-style survey. Very likely, likely, sort of neutral, unlikely, very unlikely. 23% of working physicians said they were very likely to leave medicine in the next 5 years because of the Affordable Care Act. Another 19% said they were likely to. That's almost 40% of doctors thinking that, boy, I wonder if this is worth it. Because what really at the base of this is a change in the nature of the patient-physician relationship. One example of this is the electronic medical record, something that's sort of mandated by the Affordable Care Act. And as a hospitalist, I've just recently been forced into this system, and I'm sensing an enormous amount of resistance on the part of working physicians because it just fundamentally changes how you think. It's interesting, I was talking to a psychiatrist, a friend of mine, about this new system, and his comment was fascinating. He said, when we write a note, you think through the problem in a very different fashion than when you're clicking boxes on a computer. And having been in practice for almost 15 years after 5 years of training, so it's almost 20 years of seeing patients, you sort of develop a way you start to think about the patient and their problems and how they fit together. And it's a very complex process. And what I'm finding as I use the electronic medical record, it sounds great because you can just click a button, you get all this information. Turns out you get so much information that it's almost hard to use. And the way you think, what you feel going through it has changed. It's more about, can I check all the right boxes to make sure I get all the right diagnostic codes so the hospital can get reimbursed, than, Mrs. Smith or Mr. Jones or what's going on in that patient's life. So we see this sort of top-down mentality coming out of Washington saying, here's how we're going to make medicine so much more efficient. And they change things they really don't understand what they're changing. Another thing that they're sort of emphasizing is sort of the well-being of the patient, which, of course, is what I want. And one of the ways they're doing it is they're empowering patients, which I want as well, but we do it two very different ways. What they've started doing now is tying reimbursement to the hospitals to patient satisfaction scores. There's something called a Press-Ganey score, where we get patient surveys at the end. And depending on the score, that determines the level of reimbursement the hospital gets. The problem is when you structure the system that way, it gives this disproportionate relationship, and it's taking the patient-physician relationship out of context. We're now in emergency rooms to achieve the proper Press-Ganey score, which in turn hospitals sometimes use to determine the salary of the physician. The emergency room physician knows that somebody come in seeking drugs. If they say no and don't give them the narcotics, they'll get a bad Press-Ganey score. So what ER physicians are beginning to do is simply hand out narcotics to get good scores from their patients, to get more reimbursement from Washington so they can keep their salaries. So this is fueling a system where we're dumping narcotics on the streets because the physicians can no longer be a physician. They're simply a technocrat checking boxes. And this has fundamentally changed that patient-physician relationship, and no wonder 40% of docs are thinking about leaving medicine. And I was also thinking about this in terms of policy, and again, I'm not going to spend a lot of time on policy, but switching subjects a bit to the second point. I was recently asked by someone of modest influence at the national level what to do about pre-existing conditions. And one of the things that I had in my previous proposal was the state-based sort of high-risk pool, which is a sort of a normal conservative response. And I was talking to some other people up at Heritage, and another idea came out about something called a risk transfer pool. I don't know if you guys have worked with that at all. It's a different concept instead of the high-risk pool. And this is jumping to a sort of a second subject, but it gets to the concept of federalism. So it gets to giving states the authority and autonomy to start to craft novel solutions. The basic concept between a high-risk pool, that's why a lot of people suggest it, is we take patients that are at increased risk, their insurance rates and payments are going to be higher, put them in a separate state-run pool to pull them out of the traditional insurance market that brings down the cost of the insurance market so businesses and individuals can afford insurance more easily, so you get more people into the insured pot. And that sort of makes sense, but the problem is the free market force behind that always isn't encouraging the insurance company to slide its top 2% to that high-risk pool. So it essentially creates a system of yet another taxpayer-funded system to pay for more stuff. The idea that came out of Heritage is called a risk transfer pool, which was a fascinating study where you don't have this high-risk pool. All the patients are managed in the private system. And then it's sort of a transfer system where the insurers at the state level put money into a pot that distributes risk. So if one insurer randomly gets a disproportionate number of expensive cancer patients or transplant patients, that's allocated in sort of a post hoc analysis, so they look at real data to see which company got a disproportionate number of which payments. So then it starts to get rid of this natural free market force where the insurer starts to avoid the, quote, expensive, difficult patients. So they take patients as they come. They make their money by managing those patients well. But if a disproportionate number of folks with diabetes or transplants or whatever ends up in a certain insurer, the risk is transferred between insurers. The main point I'm getting at with that is that's a state-based idea, not a federally based idea. Which moves me to my third point, which we're talking about seems unrelated again. Common Core. Last night at dinner we got out and we got into the subject of education. And what we're talking about, Common Core is essentially the same as the Affordable Care Act, just education instead of medicine. And the concept was developing. What's happening is we're watching all this power move to Washington. And we're starting to have a one-size-fits-all system, whether it's for health care or education. The Affordable Care Act is going to decimate the infrastructure of American medicine. Common Core is going to decimate how we can actually teach our kids. They're the same thing. And the solution on both counts is to get the power back to the states, which means to get the money back to the states, which gives us back to the sort of the policy position we were talking about yesterday with the block grants for Medicaid. And then Matt Mayer suggested instead of block granting Medicaid, should we just argue to keep those tax dollars here in the state to begin with, so those tax dollars never move to Washington? And in one of the chapters in my book, I'm talking about education. I read this fascinating book, came out of Notre Dame by George Marsden. It said the title of his book was The Soul of the American University, From the Protestant Establishment to Established Non-Belief. And he tracks the course of education over the last 350 years. And what he saw and found was really education was reshaped entirely because of federal dollars. And when money goes from we the people to the federal government, back to we the people with state, or back to the states or at an individual level, the feds have so much power, they can completely restructure the nation. And the big point I want to get to, because we've heard two excellent presentations about the details of Medicaid, is we have to develop a system where the states maintain control of the states. Because the expansion of Medicaid is really a federally mandated bankruptcy of the state, where the states will have to either face bankruptcy, can't balance their budgets, cut other programs, or transfer Medicaid to the federal government. At that point, the federal government will combine Medicare and Medicaid, and we'll end up in a single-payer system where we transfer yet more power to the federal government. And this really, as I sit through the lectures yesterday and just the little bit this morning, this is really a battle about power between states and the federal government, between how we the people relate to our state governments and federal government. And we're just talking about distribution of taxes. You look at your state tax and your federal tax. There's so much money going to Washington as opposed to the states. That should be completely inverted. We should be able to keep those dollars at the state level to let each state and each county, as you were talking about earlier, start to meet the needs of their people. And that's really what I see in the big picture is at stake in this entire healthcare debate. And then as we move past healthcare into education and transportation and energy as well. So my last parting ideas here, I think I'm just about done with my 10 or 12 minutes, but let's do what we can, starting with healthcare. There's an opportunity. The healthcare debate fundamentally shifted 7 weeks ago. The American people now understand the Affordable Care Act will not work. It cannot work, that they're losing their coverage. This is the moment to advance bold ideas, to give states autonomy, to reframe the healthcare debate, to make it a fiscally responsible, patient-centered effort where we can advance those ideas. And we have to capture the imagination of the American people, and this is the time to do it. We can start with healthcare, start with Medicaid, and then we can use those same principles once the public starts to understand the difference between local and federal control. Then we can do that with education. Then we can move that behind that with transportation and start to get control back to we the people. Anyway, that'll be my comments for the moment. I think we have some time for Q&A, but thank you again all for coming and the hard work you do here.